Didn't understand anything but thanks.
So I'm going to, slides please. I'm going to talk about a very specific and although very frequently encountered in everyday clinical practice, it's a largely neglected area of research in schizophrenia, and this is insight, presence of lack of insight, and also the attitudes towards the illness itself and treatment. This is something we all too often encounter in our everyday clinical practice with our patients with schizophrenia, which often they do not accept, and they disagree both with their therapist and their relatives concerning whether they are indeed mentally ill, whether all these they experience, the voices, the ideation, all these are real or pathological. And of course the most important is whether they need treatment or they can cope with this thing by themselves with their own strength. So these disagreements, this lack of awareness of illness and its consequences largely correspond to what we consider as poor insight, lack of awareness of the illness, lack of awareness of the symptoms, and of course lack of awareness of the necessity for some kind of treatment of this illness. It's not something that it is rare. The vast majority of schizophrenic patients experience some kind of poor insight, up to 80%, and it should be considered to constitute a trait, not something that comes and goes. Usually patients have a lack of insight throughout their life, at least to some degree. Of course it fluctuates depending on delusions and other symptomatology, but the core of the lack of insight usually has the qualities of a trait. And according to the WHO, it constitutes one of the 12 most discriminating symptoms that characterize schizophrenia. And if we apply methods which are more refined in the assessment of insight and its lack, then we arrive at very complex and very interesting concepts and descriptions of this phenomenon. The earlier approaches, the earlier explanations of this problem was psychological, and they were relating poor insight to some kind of denial. This is the approach of Meyer-Gross, and it was considered to be some kind of psychological strategy for patients with schizophrenia to cope with the burden and the problems of the illness. And this led to the development of the so-called psychological denial model. And it predicts that, essentially, that schizophrenia is related to poor insight, and poor insight itself is related to less distress. And there are indeed some cross-sectional studies suggesting that indeed higher insight is related to higher distress and hopelessness and eventually to suicidality. And some longitudinal studies also confirmed this relationship of poor insight with better, with less distress, and higher insight with worse overall psychological feelings. There were also some psychological studies on coping styles, and they identified some coping styles like self-deceptive positivity, the ability to deceive myself in a positive way, to tell lies to myself, impression management, escape avoidance, and positive reappraisal. Some kind of coping styles which positively deceive self in order to avoid conflict and distress. And eventually, this line of research and thought led Sparks to hypothesize a chain of causality, as we call it, from poor insight, from high insight to suicidality through hopelessness and despair. However, in the recent few decades, fortunately we have much neurobiological and empirical clinical research, and these studies relate poor insight to some kind of frontal lobe dysfunction, and this line of research and thought suggests it is a kind of anosognosia. It's another aspect of this problem that we see in neurological patients, especially in stroke. So it's an inability, not a coping mechanism, not a psychological process, but it is an inability of the patient to experience the illness and its consequence in the full spectrum. So this is not a black and white situation. This is not a yes or no situation. The patient could be partially aware and partially unaware, could have partial insight and partial lack of insight, and it can identify and experience some aspects of illness but not others. This is very important to have in mind, that this is not a black and white phenomenon. And this also concerns differentially different clinical symptoms, aspects and disability. This is, in essence, this is called a problem in metacognition. Metacognition is the way I experience myself in relationship to the others, with second thoughts, as if I can get out of my body and observe my place among the others. This is a very complex, high cognitive function which is disordered in schizophrenia. And indeed, recent refinings suggest it is the lack of insight, it is an associated feature of schizophrenia, not a coping strategy. Seems to be a trait, clinical symptom, not a coping, psychological coping mechanism. It is related to some kind of self-stigma, and it could produce some kind of hope for recovery, since we have other concepts like usable insight, the insight which allows the individual to differentiate itself from the illness. I am not a schizophrenic patient, I'm a patient who suffers from schizophrenia. And also, in this frame, it is important that we differentiate between cognitive insight and the traditional clinical insight. So, insight and lack of insight, awareness and lack of awareness of the illness differentially affects and concerns different domains of the illness. Metacognition in this frame is very important because it defines the ability of the patient to realize its place among the others and his personal relationship to the illness. And this relationship to illness characteristics is very important for insight, because it leads probably to lack of treatment adherence, at least in the short term, because in the long term, lack of insight does not seem to play that an important role. It is associated with positive and negative symptoms. Greater insight has less positive, less negative symptoms. It's not related to disability and functioning per se, although the severity of the illness is related to insight, and in turn it's related to functioning. And there is no consistent correlation between lack of insight and violence. No consistent correlation. Maybe there is a correlation between the presence of insight, depression, and suicidality. And this is an alarm. This is a point of concern because it might identify patients at high risk of committing suicide. It is important to separate lack of insight, lack of awareness for the illness, and health beliefs which are embedded in the cultural, religious, or societal background of the patient. Because health beliefs are knowledge or beliefs that come from outside of the patient. They are determined by other factors rather than the patient and his illness. And these are modifiable, at least partially, with some kind of interventions. And it is clear that poor insight and health beliefs are not related. If you have a religious cult which does not accept psychiatric nosology, then a patient who suffers from schizophrenia and belongs to that religious cult, you cannot say he has poor insight. He has different health beliefs which determine his attitude towards the illness. And it is interesting that when you have health beliefs which determine a negative stand against the illness, this does not change with treatment. Although insight itself could change, health beliefs do not. Health beliefs might change with consultation or with some kind of intervention of this psychosocial level. And such a method to address health beliefs, dysfunctional health beliefs at the psychosocial level, is the so-called motivational interviewing. But with motivational interviewing, you cannot address poor insight per se, only health beliefs. So it is important to assess the cultural, social, and interpersonal factors which influence the broader concept and the broader status of insight in the patient, whether this is insight per se or it is because of health beliefs. And it is this phenomenon is so wide and so variable as differences between different people and different cultures are, and at the same time it is so basically, so fundamentally identical between people that you need really to interview and dig inside the experience of the patient in order to understand what is happening with this specific person. And we need to have in mind that all this experience, all these inner procedures, inner mechanisms related to awareness are embedded in one's culture and in one's self. So, if we are able to assess at some level poor insight and awareness, and we see that our patients have problems there, how can we best treat? Well, pharmacological interventions in schizophrenia are highly effective in alleviating positive symptoms, but not that good in alleviating negative symptoms, cognitive disorder, and unfortunately they don't seem to have a significant effect on poor insight. So pharmacological treatment has a doubtful effect. In case poor insight is strongly related to delusions, then of course pharmacological treatment will have a strong effect. But in case you have this trait-like poor insight, then pharmacological treatment might not work at all. And then we come to psychosocial interventions, and CBT and MI are somehow researched. Again, they they are not efficacious against poor insight per se, but they are efficacious against aspects of poor insight-like symptomatology and psychological processes, like dysfunctional health beliefs. Motivational interviewing is a way to interview and at the same time elicit and reveal the inner psychological procedures inside the patient and help him to arrive at a different conclusion than the original. While CBT tries to utilize previous experience and emotions in order again to change all this experience. Conclusively, what we need to know about poor insight is that it's a symptom rather than a coping psychological mechanism, probably a trait symptom. It causes problems with the long-term course of the illness, mainly because it leads to treatment non-adherence. It's not a simple concept, it's complex, multidimensional, embedded in the social and cultural context, leads to poor adherence. It is of unknown cause, unknown substrate, and we don't really know how best to treat it. Thank you very much.